And thank you, Faith, and colleagues for inviting me here today. I'm going to talk about a project we did around how children and young people were involved in decision making in a cancer ward, and just say trying to find a balance. And Faith was on the team, Aisling Amory and Gemma Kiernan, and thanks to them. You may all know this Article 12 of the UN Convention on the Rights of the Child, which states that state parties shall assure to the child who is capable of forming his or her own views the rights to express those views freely in all matters affecting the child, and the views of the child being given due weight in accordance with the age and maturity of the child. And most places try to adhere to that convention, and most countries have ratified that convention. We also have the National Service Framework here in the UK, which states that children should be active partners in decision making. They should be encouraged to be active partners in decisions about their health and care, and where possible be able to exercise choice. That's picking up on the UN Convention. We also have the SIOP, which is the International Organization for Oncology Pediatrics, which they move it on a bit further, and they say children have a right to participate in medical decisions regarding their own treatment based on the developmental level of the child, and that doctors need to share developmentally relevant information with pediatric patients that will improve their ability to participate in the decision-making process. Now, the wording is American there, and physicians for doctors, as we all know. But that's making the point that not only do they have a right to express their views, not only should you involve them, but you should actually encourage them. And we also have the American Academy of Pediatrics, who went one step further to say healthcare providers should not exclude children from decision making without persuasive reasons. So when I looked at all the research in this area, I found that there was a complete deficit of research from children's perspectives. It was mainly from adults' perspectives, and it was mainly with regards to end-of-life decision making and palliative care decisions, trial decisions, but not everyday decisions that happen in a pediatric cancer ward, children's cancer ward. So we set about doing this project. It involved one-to-one interviews. We used participatory techniques with children. By that I mean, like, we had 3 jam jars with jelly beans, and we asked them how much are they involved in decisions, or how much say they have. And one jam jar was a little, some, and a lot. And so they could, none, a little, and a lot. And they could put jelly beans in, and a lot of the young people, children, wanted to eat the jelly beans afterwards. So we had to keep putting in requests for more jelly beans. And Trinity College Dublin, where I'm from, are very strict on what you claim for, and they were wondering why I was ordering all these jelly beans. So I had to write an explanation. But anyway, the children and young people were aged 7 to 16. They tried to move them on if they're older than 16. So it was 7 to 16, and there was 20 of them, and we interviewed their parents as well, the mother or the father, whoever was there mainly, and it was mainly mothers. The healthcare professionals, which were doctors, nurses, social workers, teacher, play specialists, and there was 40. So if any of you do research, this is qualitative research, this is a very large sample. We had a lot of data. And we were on the unit for at least a year, and the project took 2 years. And everybody was very supportive, and we were very appreciative of their support. And we interviewed doctors from consultant right down to medical student, nurses from the most senior down to the most junior, to get a flavour of people's opinions and perspectives. And it was on one cancer ward in Ireland. And I'm just going to give you a flavour of the findings from this project now. The key thing was, and this was peppered through most people's discussions, was it has to be done. They kept saying that frequently. The fact that the child required cancer treatment to survive led many parents and children to feel that they'd no choice regarding most decisions. And if you think back to those key reports and everything in the literature says, you should try and involve children as much as possible, this was quite a stark finding, that really parents and children felt they had no choice regarding most decisions. And these are two statements which illustrate what a lot of the parents said to us. I'll let you read those. So really what they're saying is, you have to accept it, you have to go with it, it's not really a decision. We signed the forms. And the healthcare professionals said the exact same thing. They said, most parents think there is a decision to be made, but there's not really. But we do need them to sign the consent forms. And we said, what if they don't? What if they don't agree? And they said, that's very rare, and if it did happen, we would take them to court probably, because it's a life-threatening illness. With regards to children's participation in decisions, they said there were small and big decisions. Decisions they classified as big were all the medical decisions, whether to have the cancer therapy. The small everyday decisions was how care would be delivered and how procedures would be done. Children were not allowed to make a wrong decision, and that strongly influenced everybody's behaviour, because cancer is a life-threatening illness, and for that reason, if you gave them a decision and they went the opposite way, then that would cause problems. So they weren't allowed to make any of the major decisions. All of the adults said they could make, particularly healthcare professionals said they could make the small decisions, which was how the care would be delivered. And for some children, they didn't term that the small decisions, because they were really important decisions for them. They said they are the small decisions. They used that terminology as well, but they said for us they're big and important. So children were seen as having a right to be involved, but not necessarily possessing the emotional maturity to make a serious or major decision. The treatments had to be done, but children could be involved in choosing how the care was delivered. And the reason most people wanted to involve children was inclusion was viewed as fostering trust and increasing cooperation. And everybody said, it's a really difficult journey. It's very, very challenging. And it's so important to have everybody on board and everybody along for the journey. And having a good relationship makes caregiving so much easier. And so right from the start, all the healthcare professionals work with the families to try and increase that trust and a good relationship and cooperation. And by involving children, they saw it as helping them to be more cooperative with the treatment, adhere to it, and non-inclusion made caregiving more difficult. This is what one healthcare professional said: they might not like it, they don't like it, but it has to be done, and that is the problem. They're talking about children. In their day-to-day care, like the medicines and things like that, but like major stuff, have their chemo on time and things like that, they wouldn't have a decision in things like that. No. And what were the children and young people's views? Well, they accepted that the big major decisions were taken by parents and healthcare professionals. And I think that's important, because sometimes in the literature around children's participation in decision making, they see it as a black or white when there's shades of grey, or inclusion or no or exclusion, when children are quite happy for the big major decisions to be taken by parents and healthcare professionals. And they gave reasons like they've done all the studying, they know what they're talking about, they have the expertise, they know how to do this, I don't know this, and they have your welfare at heart. So they did accept that, but that didn't mean they didn't want to be included. They were aware that choices over how the care was delivered were small decisions in the context of cancer care. And some of the older children, when I'm using the term children to mean children and young people, I'm talking about adolescents, 12, 14, 16, they did not see these as decisions, since they were not allowed to refuse care. And they said they're not real decisions because you cannot say no. But other children saw them as decisions when they were given decisions on how the care was delivered. So, this is what some children said. I don't really get to make any decisions. There's no really big decisions that you could say you've made. A 14-year-old boy, my opinion doesn't really matter because I have to go by their saying. I've got to go with what's on the protocol, and I just have to do it. And then the 16-year-old girl, probably hard to read that. It is, you have to take your tablets. You don't get a choice. Sorry. If you want one, you just don't get one. Just find other ways to take control. You don't get an option. What was pervasive through their accounts was that they feel a total loss of control when they go into hospital. And that loss of control affects their self-esteem and confidence. And lots of people talked about how the children and young people try to regain some control, and they use food as a way of regaining control, and they rebel. I'm seeing heads nodding here. They described loads of situations where the food becomes a battlefield because they know that they can fight that one. But as some children said to me, you know, you can't fight about the chemotherapy. There's no point in fighting them because, you know, you have to have it. But food could become an issue. So I'm conscious of the time, and I'll just go through these, the influencing factors on the children's decision making. One of the key one was age of the child. What was interesting was that when we talked to people individually, they said, some people said, well, children as young as 4 could be involved. And some said 6, some said 8, some said 10, some said 11. But we found that children generally 11 and upwards were involved a bit more than the younger ones. The younger ones were generally not involved at all. So although everybody said you can't really use age as a marker because children mature at a different rate and children have different personalities, they still used it as a broad sort of gauge, a rough gauge. Adults' attitude and behaviour. If adults feel that children really shouldn't be troubled with any decisions, they don't make much of an effort to involve them, and they display that with their behaviour. The children described lots of non-verbals where a doctor might stick his head around a door and say, have you any questions for me? And they say, well, you know not to ask a question because his head's only around the door. He doesn't want to stop, and he's a busy person. Or that they'll ask, say, have you anything else to ask? And they're looking at their watch. The children describe that. And those of you who have children know they're great observers. They sit there and they watch everything. And they observe people's non-verbals before they listen to your verbals. And when your verbals contradict your non-verbals, like you're giving a smile, but you're looking impatient, then they'll believe your non-verbals. They'll actually believe your non-verbals. Parental support. If parents didn't feel that children have a role to play, then healthcare professionals went along with that. They did try and persuade parents that it was good to be open and honest with children and to try and involve them in discussions around their care and treatment. But if parents refused and didn't want the child to be involved, they never went over the parents' heads. They respected the parents' wishes. They said it's a long journey and it's very important to keep that relationship with the parents. So they'll try and work with the parents to try and include the child. So parental support is essential. But many of the parents talked about the struggles with knowing when should you involve a child, how should you involve a child, and what kind of words should you use with a child. And they didn't seem to be receiving any guidance or support in that way on how they should involve their children. And there were some cases on the unit where the parents hadn't told the child that they'd cancer. They were using different terminology like a lump, a problem, things like that. They didn't want the word cancer mentioned. And that made caregiving quite difficult because everybody had to work around that. And sometimes healthcare professionals told a bit too much to the child, and that caused a friction between the parents and the healthcare team. And you can imagine a busy oncology unit with people coming and going and lots of staff, different rotas. very hard to maintain that, this is how much information you give. But that's another talk for another day, which is a whole tranche of data around communication and communication interactions. And I'll just say one last thing on that, and that is children pick up pieces of information from everybody. They're like sponges, and they put it all together. And they say, I know I have cancer. Even if they're not losing their hair or their things, they're saying, I'm getting loads of gifts. I'm getting brought to Disneyland. I'm getting this, I'm getting that. I can do anything I like. There's no disciplining me at all. You know. And the more bad behaviour they were let do, the more worried they were, because they said, I must be really, really sick. You know, and we said, we were told to remove the word cancer on the information leaflets for the children, because we wouldn't know who'd been told and who hadn't. And I was amazed at that. But then you have to understand, as parents explained to us, that they wanted to maintain hope and spirit. And I know Catherine spoke about that this morning, is that feeling that you know, it's like a spiritual thing, that you know you can fight this. And they didn't want to depress the children and stop them from feeling hopeful. So that's why they didn't really want to say you've got cancer, because cancer has such negative images in the media. Everybody seems to die from cancer. Time and ward routine. Unfortunately, if people were stuck for time, they didn't tend to include children as much in how the care was delivered. It tended to be done to them, and sometimes that was down to the pressure of work or a particular routine. Sometimes staff had this attitude that everything had to be given on time, and you know, so there was no leeway. But other staff had a different approach, that there could be leeway there could be discussion. You could come back and ask them about it later, give them time to absorb the fact that they needed the procedure. Communication skills. Unfortunately, it seems healthcare professionals are still using a lot of terminology that don't make sense. They use jargon, they use big words, they don't explain things, and children just zone out. They talked about zoning out because you cannot understand what they're talking about. Restricting information, if they restricted information, then it was very hard for them to take part in any decision. Health status. Children and young people talked about when they were feeling unwell or going through a really rough period of treatment, they used to put their head under the duvet, and they didn't want to be included in any decisions, and they didn't want to hear any more information. Lack of assessment. There was no assessment on the unit of children's preferences for participation, and there was no documentation of communication around preferences. So I'll just leave you with two last slides. Faith will be glad to hear. It really is a balancing act, because this healthcare professional said, I think you have to balance two needs. I think sometimes maybe the child's needs aren't primarily met, and not in a negative or punishment or abusive way, but it's done for all the best reasons in the world, within the dynamic that they have to live in, and for their own safety and protection as well. So a lot of people feel, because it's in the best interest of the child that they receive this, there's no point in including them in any of the discussions around this, because they cannot say no, and if they do say no, it's going to cause problems, or if they do refuse care, you're going to have to spend a lot of time persuading them to have the care. One nurse said, we as professionals have to think about that. Sometimes we're so determined to get a cure or task completed that in our hurry we don't stop to think, you know, will I achieve this quicker and more efficient if I stop? And sometimes you think, will I give them the choice, or will I include them? Because including them might delay us. You know, again, the big object is time. So in conclusion, children and young people want to voice their preferences and be included in how care is administered. And they do prefer shared decision making, not necessarily responsibility for decision making. And often adults think it's about giving them responsibility and allowing them to make a big major decision on their own. None of the young people spoke about wanting that. They said they prefer to be included, but for the adults to really help them make that decision or to take it on their behalf. Healthcare professionals need skills training in how to support and facilitate children and young people's participation. And parents need clear guidance, support and education on how they can share information with their child and how they can support and facilitate their child's inclusion in decisions. Because one of the concerns raised by this was that if a parent is not including a child at all, we met parents who had young children who were age 14 who were still not being included. And the concern is there that if parents don't gradually start to include the young person, when will they ever learn the skills? And when will they ever get a way to voice their preferences? So parents might need time to move towards a more inclusive approach with the children. Harry Shear's work is quite good in this area, and I like his levels of participation, because when we were trying to put together a framework for how children should be involved, the key thing that children talked about was that they were listened to. They said they didn't feel they were listened to as much as they should. So are you ready to listen to children, and do you work in a way that enables you? Children supported in expressing their views was next of importance. Their views taken into account, involved in decision making, and then share the power and responsibility for decision making. Very few wanted that, but maybe if they were aged 16 and upwards they might have, but we only went as far as 16. Thank you all. And thanks to Lisa. That's my email there if anybody wants a copy, but I think you'll have a copy anyway.